Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research-based information about cancers and their treatments.
Hello, I'm your host, Dr. Prasad Dandekar. I'm an oncologist and I head the Radiation Oncology Department at Sir H.N. Reliance Foundation Hospital in Mumbai. Thank you for joining today for this conversation about the most dreaded chemotherapy. And to have these questions answered for us, we have Dr. Vashishth Maniar, who's a medical oncologist practicing in Mumbai, but also one of the most well-known faces in the field of oncology in India. Dr. Vashishth Maniar has been one of the most popular medical oncologists around, and I'm sure all of you would have heard his name. So welcome, Dr. Maniar.
It's such a pleasure to be here, Dr. Prasad.
So, Dr. Maniar, I'm very curious about what got you into oncology. I mean, it's not the field that it comes naturally to most of us. It's almost many doctors also feel dreaded about it because it's so morbid and patients have so many issues. What got you attracted into oncology?
So the cliched answer would be, oh, I always wanted to make a difference in everybody's life, and I was so driven by a purpose. Wish that were true. The honest answer is, it is as accidental as oncology is as a branch, right? When I use the word accidental, we believe that cancer is often an accident, which happens to people who are not supposed to have one. So oncology happened to me when it was not supposed to be a part of my life. I did my MD in medicine from Sion Hospital, and we were trained then as residents about a couple of decades back that if you see an atypical cell which looks potentially cancerous, refer them to Tata Memorial Hospital, which was the closest hospital which treated cancer patients. And that was the job of a physician. And that was how ignorant I was to oncology. It was only post my MD, I happened to give an entrance exam for doing super specialization. I got reasonably decent marks. And I thought I had some more time before I eventually chose a subject. And I got into oncology purely by accident. And the moment I got into oncology, what interested me was that I was extremely passionate about medicine in general. And one of my paranoias of super specialization was that I would now be being fair to only an organ, being the heart or the lung or the kidney. And that would take me away from my primary core passion of being a physician. And the moment I deep dived into oncology purely by accident, I realized it mirrored medicine so much because I did not have a choice to decide which organ the next patient would come with. And hence I could enjoy my proficiencies of being a physician and treat every organ of the body. So that dramatically interested me. And then I took as fish does to a water, and I loved oncology. And yes, it's been a phenomenally fulfilling and a gratifying journey so far.
And we can see that in the work that you put in. I mean, every patient that I see who has met you treats you like, oh my God, Dr. Maniar is my closest friend and he's got to us because, he's so fantastic. And I think that passion can only come if, that sort of patient satisfaction can only come if you have that passion in you and you want to do good for your patients. So that's very, very visible in the work that you put in. And you're absolutely right. When patients come into even my clinic, there is this sense of tension that, oh, what am I going to do next? What sort of challenge that I'm going to have? It's not something which is very boring. Our jobs are so very interesting. And as a radiation oncologist, when I see patients, one of the common questions that I get from them is, what is chemotherapy? How does it act? Because many of our patients are taking chemotherapy either before or after or along with radiation. And for me, as a radiation oncologist, it's very easy to explain how radiation works. But when it comes to chemotherapy, there's a lot of confusion in patients' mind. Would you like to tell us a bit more about that?
Most definitely. I believe, so I'll just try and, if I'm allowed to, dwell back on the doctor-patient relationship that we spoke about, right? So Dr. Prasad, what I was taught very early in my oncology days and training from my PG teachers is that often the conversation between a doctor and a patient is we have a table in front of us and there are two people on either sides. I believe that creates a certain mindset that it's A versus B, and B is supposed to ask questions and A is supposed to be diligent about it and answer it in the right way. That's not how a physician should be, right? He should be somebody who can put an arm over the patient and tell him, you know what, we've got this. Yes, we understand you're not supposed to be here, but let's try and solve this problem for you. And when we realize that we have two people sitting on the same side of the table, harmony flows, faith flows, and then you as a physician have the responsibility of taking decisions which are in the best interest of the patient. And it's often not only science, but a beautiful interplay between science and art of what should be the next step. Otherwise, a chat GPT would do a better job if it's pure science. So I believe it's that compassion, empathy, and being on the right side of the patient, which allows us to be what we are and enjoy what we are doing.
Yeah. So I was having a conversation with Dr. Vanita Narona the other day, and we both basically said the same thing, that we are on the same side of the table as the patient is, and the cancer is on the other side. We are in this fight together with them. And chemotherapy forms a large part of the treatment for the patients for a lot of cancer, especially common cancers like breast cancer, cervical cancer, head and neck cancer. So how does it act?
So, Dr. Prasad, incidentally, as I'm an incidental oncologist, chemotherapy was a pure incident or an accident. If I'm allowed to dwell back into the history of medicine of cancer, which is chemotherapy, one realized that post the World War II, people who had exposure to nitrogen mustard, which was a chemical which was used as a weapon, had bone marrow suppression, where the hemoglobin, WBC, and the platelet would fall, and it refused to improve over a period of time, certainly telling us that this nitrogen mustard gas did have ability to kill bone marrow cells. And as humans are intuitive, they realized if they can kill your normal bone marrow cells, it probably may have the ability to kill abnormal cells also. For that, let's understand what is cancer in its first place, right? Cancer is not an infection. Cancer is not an inflammation. I, in fact, often romanticize cancer as being a more evolved version of your own self. It's the X-Men of your own body, where there are cells in your body which have found a way to now exist using the resources of your normal cells and are probably hoping for immortality, meaning that these cells often divide faster than your normal cells. And nitrogen mustard seemed to probably kill these faster dividing cells which were there in the bone marrow. So mustard or mustin was the first chemotherapy that was used in certain cancers like lymphoma, because we by then had known that cancer cells divide faster, and hence if you have a drug which specifically targets faster dividing cells, these cells would die more often. It was also a very curious play between using the right dose, because if you used a higher dose, then you would kill the normal cells also. The most fascinating part about oncology is there a huge Indian connect to it, which somehow is always forgotten. The most revered name in medical oncology is Sidney Farber, who was part of the Dana-Farber Institute at Harvard and is now one of the most revered oncologists of all time. But little is known about an Indian called as Dr. Y. Subbarao, who played a massive role in probably giving us the most important oncology drug. So historically, what Dr. Farber did was, then acute leukemia or blood cancers was considered as a non-treatable disease, and just to palliate their symptoms, he would give them vitamins. They realized that the moment you give these patients, sick acute blood cancer patients, vitamins, they would die faster. And hence the analogy, if a drug is probably helping the cancer cells, wouldn't a drug which is an antithesis to this stop the growth of the cancer cells? So he wrote to Dr. Subbarao, who was a physicist of Indian origin and who was working on these antifolates as a chemical compound. And he wrote that, you know what, doc, I'm seeing that if I'm giving folic acid, these patients are dying faster. So can you help me develop a drug by which I can stop the folic acid from being there in the body? And he then developed a drug called as aminopterin, which is the first antifolate, then eventually methotrexate, which became the standard of care in acute leukemia patients, and people dramatically live longer. And acute leukemia was no more relegated to the ugly lobbies of the hospital where young children were just meant to die. And suddenly in a few weeks you saw these young boys and girls getting up, moving around, playing. So that's the genesis of oncology, specifically medical oncology, because historically in the past people believed that the only way to kill cancer was to either burn it, then by x-rays, or to remove it surgically. It's only now that we are wiser, we realize that cancer is largely a systemic disease which expresses locally. And if you can change the systemic biology of the cancer, you can actually create long lasting remissions. And that's how chemotherapy, which was relegated then to palliative care as an end of life comfort medicine, has now become prime time, where for a significant amount of cancers, except for head and neck, where chemotherapy may have a limited role, it's become the mainstay of driving the cancer biology and understanding who needs what.
Such a fascinating story, and how things have evolved over a period of time. And what is interesting is, in today's day and age of new drugs, immunotherapy, targeted therapy, and everything coming together, methotrexate is still very much there. It's solid. In fact, the role of methotrexate is now coming back with oral metronomic chemotherapy, where we are using it to give it as a palliative treatment. So that's really amazing to see how things don't change much, even if new things are coming in.
Absolutely. There are new drugs which would be the cherry on top, but for sure, these conventional age old anti-neoplastic treatments still hold fort in so many cancers.
Yeah. And I think with evolution of medical oncology, another thing that has happened is the effectiveness of radiotherapy and surgery has also improved, because earlier we were doing these treatments in isolation, that we were only doing surgery for breast cancer, for example, or then we added radiotherapy to it, and somehow the results were not that great. But now we have this beautiful combination of chemotherapy, radiotherapy, surgery, immunotherapy, targeted therapy, and that is sort of creating a combined, comprehensive approach to cancer care. And that's really changing the way we are looking at things.
In fact, Dr. Prasad, I mean, all of us, we've always benefited from history. Breast cancer is a prime example of how we have migrated from the Halstedian school of thought, which meant more aggressive surgeries. So, as few of us would know, Professor Halsted was one of the most renowned breast cancer surgeon, and he was the one who invented modified radical mastectomy, and he was driven to a point to get rid of cancer. So initially it started with a mastectomy of removal of the breast, and then he realized that the cancers would recur, so he started removing more and more of the axilla. He would see that the patients would still recur, so he would do massive reconstruction, removal of the chest wall, the lymph nodes in the neck, the opposite breast, the uterus, and the ovary, all with the purpose to ensure that the cancer would not come back. And in spite of these ghastly surgeries, which would really impact the quality of life of a patient, these cancers more often than not would come back. Then came the Fisherian theory of breast oncosciences, which told us that it's eventually a systemic disease. So, unless you combine good systemic therapy to good loco-regional therapy, patients are not going to live long. And now we've seen the dramatic drift from massive surgeries to good neoadjuvant chemotherapy, specific lumpectomies, and then even now fast forward radiation techniques where we do a high dose intensity radiation in a very short span of time, which has dramatically changed the way these cancer patients look and feel about themselves. So from ghastly massive surgeries, now we've come to 1 centimeter lumpectomies with a sentinel lymph node dissection where we just remove a couple of nodes, and the quality of life of these patients is phenomenally well preserved.
Absolutely. I mean, you reminded me of Dr. Indranil Mitra, one of the most senior surgeons and a researcher in breast oncology. In Tara Hospital, every meeting he would say, breast cancer is a systemic disease. You have to treat it systemically. And to a certain extent, there was some resistance from the surgeons, even, I'm talking about 20, 25 years. But with the advent of hormone therapy and now the systemic therapy, chemotherapies that we have, I think it is settled now. These cancers are systemic, and you have to treat them as the whole body, not just as that organ or that site. So that's really a big change or a paradigm shift that has happened in cancer care.
Absolutely.
When patients think of chemotherapy, I feel more often, rather than thinking about cure, they're thinking about toxicity.
Yeah.
And they're so scared of toxicity. So what is happening here? Why do we see so many toxicities, and what are the common toxicities that you have been seeing in your clinic?
Yeah. So, honestly, 80% of the time that I spend in a consultation is about warming them to the idea of chemotherapy, because of the age-old adage that if you take chemotherapy, You're going to burn a part of yourself, and it's going to be so toxic that often cancer is a better way to die than take chemotherapy, uh, which is something that we still face in our day-to-day practice. And then probably comes from the information that they've had of maybe a loved one taking systemic chemotherapy 25, 30, 35 years back, and then probably suffering. Because let's be honest, these are cytotoxic drugs. They do cause a lot of collateral damage, and they would then, and we had nothing that we could do to allay the anxiety and the discomfort that a patient would go through. Why there has been a drift in how the chemotherapy medicines have evolved? There has been a massive shift in how we manage the side effects of chemotherapy. I often ask them that what was the kind of mobile phone that you had 20 years back, and isn't the one that you use any better? If mobile phone as a technology has evolved, wouldn't our understanding of how we deliver chemotherapy would change? So, understandably, what does chemotherapy do, and why does it cause side effects? Right? That's again understanding the basic genesis of cancer. We all now agree to the fact that if this is the pace at which your normal cells are going, cancer cells grow at a faster rate. And hence, these drugs selectively kill cells which grow at these faster rate. However, there are certain cells in your body which also grow at a much faster rate compared to the rest of the body. Which are these? These are your hair, these are your nail, your oral cavity cells, your GI tract. And hence, as a part of collateral damage, when your drug is targeting these faster dividing cells, in a significant number of chemotherapy drugs, you will have these cells which are dividing faster than the rest of your body, predominantly your hair, so you will experience hair loss. Oral cavity, because these cells die, one may get small oral ulcers. Similarly, one may get diarrhea and some skin dryness. Now, does it mean that everybody suffers through these quantum of side effects? Absolutely not, because there has been a massive shift in the availability of supportive care by which we give certain drugs which significantly reduce the side effects of nausea, vomiting. We have cool caps which significantly reduce the hair loss. We have medicines which significantly reduce the frequency of constipation or diarrhea. To be very honest, Dr. Prasad, in the last 1 year of the thousands of chemotherapy patients that I might have treated, I do not remember more than a few of them who have required hospitalization for care, meaning that 95% of these side effects are beautifully managed because of our ability to preempt them and treat them successfully. Often, what happens is some of these patients in the past might have taken chemotherapy at places or in centers which do not have a medical oncologist. They might have gone to a tertiary care center, taken a chemotherapy protocol, and they would go to their area of comfort in a small nursing home run by a gynecologist or a physician who probably is not tuned to understanding how to take care of these chemotherapy side effects and hence does not anticipate them. And he only treats them when they come. Now, us as medical oncologists are trained to anticipate and prevent these side effects. So, if these chemotherapies are delivered by trained physicians, it's very, very rare that one of these toxicities would be overwhelming enough for us to really contemplate giving them at all or not.
Indeed, I mean, you brought me back memories of one patient. I was so shocked. We had seen him while I was in Tata Hospital in training. He had a seminoma, which is a highly curable disease, and he was started on chemotherapy. Very curable disease, and he was tolerating chemotherapy well. He was not from Mumbai. And that patient died not because of tumor, not because of chemotherapy. He died because of dehydration due to vomiting while he was in the train. Because we did not have ondansetron back then. And then, ondansetron came as a chemotherapy, sort of avoiding chemotherapy induced vomiting. And it has completely changed the way we are delivering treatment. You mentioned cool caps. Few months ago, I think a year and a half ago, I saw one patient. She had advanced breast cancer. She had surgery, and she had come to me for radiotherapy. And when I looked at her, I was like, "Why are you here? Don't you have chemotherapy to finish?" And she said, "No, I finished my chemotherapy." And I couldn't believe it because she had all her hair. So she said, "I actually had very good hair. I lost some of my hair, and I started using this new thing called Cool Cap. And it was magical. And the patient was so happy. She said, for me, one of the main fear was losing hair is not actually the problem. She said, my main fear was I will have to explain to every person whom I meet what cancer I have and what treatment I'm having and how I am doing. And I didn't want to do that. She said if I didn't have this cool cap invention to offer, I would have probably not taken chemotherapy at all. And that's really sad. I mean, it's been one of the very significant change that has happened. I mean, our hospital uses it, your center uses it, but not many centers have still sort of started using them. And I hope that more and more centers get on with it, because it is not just the side effect, it completely changes patients' social environment, that they are able to go out and be with their family and friends.
In fact, the world still unfortunately judges you if you're a cancer patient. Nobody judges you, or if you're a hypertensive, if you're a diabetic, if you've had a fracture, because of the age-old adage that, oh, if you have cancer, you are likely to die. If I'm allowed to digress, the funny part is that cancer was never taken seriously, and nobody thought that cancer can kill. And because nobody thought cancer could kill, it did not become a state or a national problem. So, in the late 1950s or 60s in the West, there were these cancer crusaders who wanted the government to invest in cancer care. And hence, they started giving up these advertisements that cancer kills, cancer is life threatening, because they wanted to drum up social support to ensure that the government listens and invests in cancer research. That's how the NIH came into being, and you have the National Cancer Comprehensive Grid or the network in the US. While it served the purpose then of kind of creating a buzz around cancer, where that if you do not treat, it kills, uh, it really left behind an aftermath of still the adage that if you have cancer, you're likely to die. And hence, I'm sure you must be facing that every day in your practice, where anybody, even with a 1 centimeter small tumor in the breast, is to the tune almost resigning to the fate that, oh, probably I have little life left in me. And then the hair loss adds insult to that ignominy of being diagnosed with a malignancy, and the world starts looking at you so differently. And a lot of people don't want or don't enjoy this sympathy or empathy. So having these newer technologies which can prevent these age-old typical chemotherapy-related side effects lets them live with so much amount of dignity. So it's not about as much about hiding that they have cancer, but the fact that you can look up in the mirror and see no physical dysmorphism. So no ghastly surgery now, small lumpectomy, simple radiation which gets over in a few days for the right patient, and no hair loss. I mean, this is what we all imagine how cancer should be and would be treated when we all were students, and we seem to be getting there already.
Yeah, I remember in 2001 when I got the Tata Hospital seat, the first thing I did, I went and met the consultant there. I remember going and meeting Dr. Rakesh Jalali, who was then in Tata. Do you think this is a right decision? Is there future to this branch? And just like 20, 25 years later, here we are really struggling to cope with the amount of work that we have and the number of patients who have, really shot through the roof, unfortunately. But that's the nature of this beast now, and I guess we have to deal with this aftermath, as you said. But when it comes to chemotherapy, patients often ask that, why are you recommending chemotherapy to me? The patient before me didn't receive chemotherapy. Why do I need to take it? How do you decide? How do we answer
No,
that?
so completely. I mean, often for example, if you have a young female who has a triple negative breast cancer, with a very small localized lump here, and the surgery has already happened, it's so difficult to convince that patient for chemotherapy because they feel that they had a small lump, it's been removed surgically, and shouldn't that be the end of it all? And then I have to again go through the Fisherian theory of medicine and explain that it is indeed a systemic disease. And while we've done these mistakes in the past, where we thought that just removing the tumor should be the end of it all, we've realized that these cells often teach your normal cells enough information and let these cells leak into your systemic circulation. These are called as micrometastases, often called as circulating tumor cells, which are currently not being seen on a scan, but sooner or later they will hone in on any one organ and create a new home, what we call as metastases. Similarly, in all cancers, colon cancer, breast cancer, stomach cancer, you have a patient who's undergone a surgery, removed a part of the colon. The tumor was in the colon, it was there in few lymph nodes. And if you do a PET scan today, you will realize that there is no cancer. So the first question that we are asked is, hey doc, the tumor is out. It was there in a couple of lymph nodes. I've again done a PET scan, though my surgeon or my physician did not ask me to, because I wanted to be sure that there is no cancer cell seen. So what makes me, my surgeon, refer me to you, and what makes you insist on taking systemic therapy? I often give them a very simple example. I tell them that, you know what if you had a bomb blast in Churchgate station, and at the same time there was another blast in Andheri station, and we had the police went to Churchgate, it went to Andheri, and ensured that locally both those problems would be sorted. Should that be the end of it all? Should we all just go home, sit, relax, have our coffee, or you would activate intelligence systems, your polices, to ensure that there are no blasts, right? So when a cancer has similarly left A organ and is now being able to migrate to B place, just removing A and B might not be the end of it all. There could be this small cancer cell who probably would be sitting on Western Railway on the platform of the other, deciding which train to take to Western or Central suburb. And these cells in motion are not seen on a scan. When will they be seen on a scan? When they already have attacked somebody and caused a blast. So these cells in motion is what we fear and dread. These are called as, again, micrometastases or microscopic circulating tumor cells, which chemotherapy has a huge role in killing and hence dramatically reducing the risk of recurrence. So it's the police which is now looking at the entire city of Bombay and beyond, and not just those two surgeons who have removed the Andheris and the church gates of the world.
Absolutely. And I also emphasize on them that, there are guidelines which are formed on the basis of evidence. So in fact, we have one episode coming up with Dr. Indranil Malik, where he actually explains to our viewers only about what is evidence-based medicine, what is data, how do your doctors sort of choose the treatment that they are recommending to you. Because even for radiation, it becomes so difficult. It's a tongue cancer patient who comes to me saying, my doctor has removed, the surgeon has removed the tumor. They asked me to come to you, but why do you want to give me radiation? Everything is negative. And then when we explain them that, yes, this will reduce the chance of this disease coming back, they said, how sure are you? And that's like a difficult answer to give, that how sure I am. So they're saying, how sure are you that there is disease, and how sure are you that your treatment will give me 100% cure rate? And that's a question I'm sure you also get very often. You give me chemotherapy, can you assure that I will never get cancer back?
So I tell them that the only people who can assure are the shrinks of the world, who can cure every disease without even treating them. Life is about probabilities, right? We don't ask this question when you hop onto a plane, when the lady is telling us how to put on our seat belts and where are these oxygen masks coming from. And we still hop onto the plane fully realizing there is a risk that the flight may be late, rarely the flight may crash, but the need to go from A to B is far greater. All systemic therapies and local treatments of cancer are technically risk reduction strategies. So I tell them not taking chemotherapy in certain cancers is similar to blindfolding yourself and running amok on a busy road. There is a chance that you will not be hit and you will not die. But if I keep my eyes open and cross the road, the probability of me dying significantly reduces. Similarly, there is enough evidence to believe that for the right patients, taking good systemic chemotherapy dramatically reduces the probability of the cancer coming back. The probability of any cancer coming back is never going to be zero. That goes back to genesis of understanding why cancer happens. In most patients, cancer happens by accident. In a few, it happens by an underlying predefined germline event. Accidents can happen till the time your cancer cells divide. The day they stop dividing, you're probably dead anyways. So every human being, till their last breath, will have a susceptible risk of these cells dividing in an abnormal way, and your innate immune systems unable to or are incapable to find these abnormal cells and kill them before they manifest in the form of a tumor. So I tell them that taking chemotherapy is like crossing a busy road with your eyes wide open, and it dramatically reduces the risk of accidents.
Yeah. And we did one episode with Dr. Sareen about hereditary breast cancers and hereditary cancers overall. And he also sort of brought in these views that, patients, especially when they're BRCA positive, then their worry is, should I do this? Should I do that? Should I do nothing? And patients are even reluctant sometimes to even do tests. Um, Talking of tests, I was thinking about Oncotype DX and tests similar to that. Do you use them in your practice to decide?
Very, very often. So previously, Dr. Prasad, one believed that every breast cancer patient would require chemotherapy. And often there were subjective decision factors that, oh, you're too old, why are you taking chemotherapy? Can we avoid? Oh, you're too young, you better take chemotherapy. So there wasn't enough objectivity for certain gray areas. For tumors which are less than 5 centimeter in size, which have spread to less than 3 lymph nodes and are strongly hormone positive, the evidence of chemotherapy was not so robust. However, we would use our discretion often of younger patients benefiting more with chemotherapy, elderlies, we tend to avoid chemotherapy. We also look at how good, bad, ugly the patient and the doctor's experience has been. For example, if me as a physician, I have seen 3 recurrences since morning, I'm more likely to suggest chemotherapy because of the fear of the disease coming back. So there was a lot of subjectivity because this was a gray area of oncology. Yes, a proportion of patients significantly benefit with chemotherapy in that setting, but chemotherapy is not for all comers. If you have less than 5 centimeter sized breast tumor, if you are strongly hormone positive, and you have 3 or less than 3 lymph nodes. Then came Oncotype DX. Oncotype DX is a validated test where they would do on the breast biopsy tissue and run through certain parameters, about 23 of them, and then they've created an algorithm by which retrospectively they've tested that in more than 5,000 patients of seeing that if you had a certain score and what if you took chemotherapy and if you had a certain score and what if you did not take chemotherapy, and they realized that in Oncotype DX if you have a certain score of 0 to 26, you are probably least likely to benefit with chemotherapy. Having said that, is this the only proprietary test available now? No. There are so many of them. We have in India, we have Can Assist Breast, which does a similar job. You have myriad based certain tests, which at least 5 to 6 of them, EndoPredict, which have now curated scores tell you what is the likelihood of you benefiting with chemotherapy. While this is currently restricted to a certain type of breast cancer, now there are similar tests even coming in for colon cancer, where there's an early study going on, where in early stage colon cancers up to T3 with or without up to 1 or 2 lymph nodes, one does what is called as a circulating tumor cell DNA. And if the circulating tumor cell DNA load is below a detectable level, then they are offered only surveillance and not chemotherapy. While the data of that is yet to become prime time, it's yet to be validated in terms of the 5 year and the 10-year survival. But from not doing anything for anybody to doing everything from everybody, we are now becoming wiser, where we believe less is more, and we are trying to find out those individuals who probably do not need systemic therapy using better ways of investigating in terms of circulating tumor cell DNA, looking at certain other parameters, the oncotypes and the canicists of the world, to predict the likelihood of benefit with chemotherapy. And if the likelihood of benefit is statistically not significant, they're often not given chemotherapy.
Yeah. I think we are moving gradually towards a more personalized and customized treatment for our patients, where we are optimizing the treatments rather than just doing more. And I hope one day very soon we have these tests for radiation also, because in radiation we are still in the process of looking at the pathological factors, the clinical factors, the patient factors, and deciding when to use. And there's a dearth of these sorts of predictive tests in radiation oncology, and they really need to come through. But hopefully soon, in the way we are going through all the technological advances. Now,
Eventually, sorry, I'll just complete that if you don't mind. We probably are already hitting the right spots in medicine and medical oncology there, at least for a select few patients. For example, one may often ask that, you know what, one of my friends underwent chemotherapy, he had no side effects. And another friend underwent the same chemotherapy for the same cancer and had a plethora of side effects. Why is that so? Because each human body has differences in its ability to absorb, digest, assimilate, and excrete chemotherapy. This is known as pharmacogenomics. We are now understanding pharmacogenomics better. There are certain predictive tests like the DPD tests for predicting toxicity to a certain drug called as 5-FU or capecitabine in colon cancers. And now there are multiple such being new investigations in terms of pharmacogenomic studies being analyzed by which you can predict responses and predict toxicities. Again, not prime time yet, but I don't see that vision very, very far. Where for every cancer patient, we may be able to tell you that yes, for the whole world, we may be giving 6 cycles of chemotherapy at a certain dose, but looking at your pharmacogenomic profile, for you, maybe three may be enough, and maybe at 50% of the dose, because your genes and your enzymes are wired in such a way that it will have the same impact that it would for somebody who may otherwise need 6 cycles of chemotherapy. So that's what personalized medicine is all about. We often believe that personalized and precision medicine is about writing more expensive drugs. It is about giving more expensive experimental therapy. That's really a misnomer. Personalized medicine is often understanding the requirement of that cancer patient's journey and just giving him optimum therapy, which ensures that the cancer does not come back, but also you do not cause unnecessary collateral damage in terms of impact on its quality of life.
Yeah, and I see a lot of sort of a hype around this word precision oncology, and now everybody is a precision oncologist. And but unfortunately, I do see what you're saying, that there is a lot of emphasis on using new things, and patients also sometimes feel that if you try something new, it's going to be better. Um, that may not be always the case, and we always fall back onto guidelines and what is the research suggesting, what are the clinical trials telling us. And you and I both participate in multiple tumor boards where we have experts. Like in our tumor board, we have medical oncologists, radiation oncologists, surgical oncologists, radiologists, pathologists, nuclear medicine specialists, everybody coming together and discussing these cases and sort of trying to optimize the treatment for the patient rather than trying to give maximum. Many patients, and you would know, they come to me for opinions regarding radiation, and I say, you don't need radiation. And some of them are shocked. They say, why are you not giving us radiation? It's like, but because you don't need it. I mean, we can give it for the sake of giving it, but you don't need it. You will actually cause more harm than doing good in your case. So, yeah.
We are exactly asked the same question, Dr. Prasad, that if you have an early stage colon cancer patient and you have prescribed them 4 cycles of Capox, which is the chemotherapy. By the way, you do not have hair loss in colon cancer and so many other cancers. It's restricted to few chemotherapy drugs only. And they said that, you know what, doc, I've done my research. There are 5 new target therapy drugs in colon cancer. There are 3 new immunotherapy drugs in colon cancer. Money is not the problem. Aren't you capable enough to give me this new age medicine? And wow, I spent the next 45 minutes explaining why they don't need it. Because there is, as you mentioned, evidence-based medicine. There are enough scientific evidences to believe that certain medicines, though very effective in advanced colon cancer patients, have not become a part of routine standard protocol because they do not add to your survival. So I often tell them that you can walk into a hotel and you may be able to afford the whole menu, but you only eat what your body needs. Similarly, for the sake of it, giving target therapies and immunotherapies in an effort to kill cancer may probably cause more collateral damage, because for your stage and your type of cancer, this is just enough. And that often is a far longer conversation than just telling them you need, a few cycles of chemotherapy. Uh, and coming back to the world of precision oncology, uh, I think, Dr. Prasad, it's that word should not exist, because as a physician, as an oncologist, you better do precision based medicine. I mean, isn't that a part of the charter of becoming a doctor, that you do what your patient needs? And that should not be a USP at all. So I'm a medical oncologist who has historically always been doing precision based science. So, but yeah, yes, you're right. It's the world is moving towards immunologists and precision based oncologists.
Yeah, we in fact had one more episode on immunotherapy alone as well, because we have a lot of these doctors who are not even oncologists trying to do immunotherapy. So we address those issues also in that conversation. And while you and I are trying to give optimal therapy and maintain quality of life of the patient, that sometimes opens another sort of box of questions about lifestyle. And I can't tell you how many patients ask us about sugar and exotic fruits and all sorts of different fancy diets, like this dietitian said only eat that and the other one said only eat at this time. What is your advice to your patients generally?
So I tell them you eat anything and everything in the world except human beings. So and my mind and the family's mind space. So unfortunately, diet in oncology has become a huge USP. Uh, it's become the fancy of new age nutritionists, which are available dime a dozen on Facebook, Instagram, who seem to have cracked the code of how to prevent and treat cancer. And I really hope they get their Nobel Prizes soon because I guess the world is struggling and they would really benefit from their knowledge. Uh, but that's actually demeaning the entire cancer treatment. If one could just stop wheat or stop sugar or stop milk, and if you can prevent or treat cancers, uh, wish life was so simple for all of us. You and most of us would be holidaying in Goa and not worrying about a Monday morning 60 patient OPD lineup. So diet, I believe, is extremely overrated. But yes, with chemotherapy, you would want to suggest certain lifestyle changes which dramatically help coping up with cancer therapy and cancer in general. I believe enough evidence is now available to believe that being physically active, indulging yourself in a sport is so important. Previously, one believed that if you were on chemotherapy, you better sit at home, wear a mask, don't leave the room, because we then did not have growth factors. We were worried that after you give chemotherapy, your counts may fall and you may catch up an infection. That was 1990. In 2025, if you have any solid cancer and you take chemotherapy, most likely you'll be given certain injections post the chemotherapy, which artificially stimulate your immunity enough to prevent the secondary infections. And I want my patients to play a sport, run, jog, play tennis, play football. And it's an absolute myth that sitting at home is going to make them safer. In fact, we have enough evidence to believe that if you are having a sedentary lifestyle after being diagnosed with cancer, it increases the risk of recurrence. So, remaining physically active is extremely important and it significantly reduces the risk of the cancer coming back. Coming back to diet and nutrition, one may to some extent agree that loading yourself with sugar and carbs is actually not giving you the right kind of nutrition, and in the long run sugar increases obesity, and obesity to some extent is linked to carcinogenesis. But having your chai with sugar or having a spoonful of sugar in your daily coffee and the entire guilt that they come up with, you know what, doc, I had chai and it had sugar and my husband screamed at me that, oh, now your cancer is going to come back and you don't blame me for this, which is so unfair to somebody who is dealing with enough. So a healthy lifestyle, in fact, what I tell most of my patients is what you've been eating for the last 65 years or 70 years till the time you're diagnosed with cancer, if you're that age, is probably what your body needs. So if you now at the age of 70 need a nutritionist to tell you what kind of rotis to have and what amount of ghee to put, isn't that unfair? Uh, I asked them, would you allow anybody else to interfere with your lifestyle or your financial advisor at the age of 70 of telling you how to invest if you yourself know what to do? If the answer is no, then why would this answer be yes? And I also asked them, how seriously do you take other information? For example, we have these Insta reels, Facebook reels of, put money here and the money multiplies. And you very conveniently delete that reel and don't even bother about it. There you believe this is not scientific. But tomorrow, suddenly you don't mind getting up at 5 and having a hot, warm lemon squeezed in some exotic ramphal, sitafal, and assume that is going to take away the cancer. That also stems from, I believe, Dr. Prasad, the inability of the family to contribute. Where if you have a patient who's diagnosed with cancer, you have four relatives who are very keen to contribute. Now, they don't understand science. They understand Facebook, Instas very well. So they open up their Facebook, Insta accounts and find out which is the best way, what is the best diet to give cancer. And we have enough cancer crusaders who would fill their ears and minds up with exotic diets, which there is enough scientific literature to believe that not only they don't help, but now there is evidence to believe that they harm. Too much amount of antioxidants, lycopenes of the world. There is a recent paper at St. Gallen which tells us that they increase the probability of the cancer coming back. So also, I think another huge myth is a problem that I struggle with a lot, and I'm sure that is alternative medicine. What would few pills of homeopathy do? They may change how these cancer drugs act in my system. Oh, but doc, you know what? My homeopathy or my Ayurvedic doctor said that you take these two pills and it is going to reduce the side effects of chemotherapy. My fear is, what if they reduce the effects of chemotherapy? In an effort to reduce the side effects, what if they have certain enzymes, which a lot of these drugs do, called as CYP3A4, which is a metabolizer in your body, and it hastens the metabolism of certain products. And if these drugs hasten the metabolism of chemotherapy, it just makes them significantly less effective. So I've had patients who've told me, Doc, I took the first two chemotherapies, I had certain side effects. While you gave me medicines and I was okay with it, the next two I added these couple of Ayurvedic concoctions and now I have no side effects. I've even started gaining hair and I'm alarmed. I tell them that you're kind of undoing what I'm trying to do here. So I'm very, very wary of these self proclaimed cancer healers. And hence, I do spend that extra time and effort, and I'm sure all of us do, to try and put more sense into this entire discourse that, look, we're looking at a very, very well defined, scientifically developed, evidence based medicine which needs to be taken for a certain time period, which reduces the risk of the cancer coming back. Let's not mess around and do anything exotic. Let's not use Facebook, Instagram, and other social media platforms to define your cancer journey and rely on science.
Yeah. And that's what they call it. WhatsApp University has now become like a big headache for all of us. And it is very harmful. I mean, it is very often that you and I see patients who actually had a curable disease, but then went through different alternative treatments and then came to us with a large disease which unfortunately cannot be cured. And it's really, really very sad to see this happen. But that's something we see really very often.
It happens in all walks of life. Don't you think so? We have enough people who scam people of their money. We have enough faith healers who cure diabetes, HIV with some mantras and some holy waters and some concoctions. And gullible people do fall for it. The unfortunate fact is that while these in the past were working in silos, thanks to social media and advertisement as being a huge platform, these have now become prime time. And this is a very unique challenge because this is not there worldwide. This does not happen as often in Europe or the US, where you spend the next 30 minutes telling them what not to do rather than what to do. The decisions and the discussions are far more scientific then. And it's a huge menace, if that's probably the most mildest democratic word that I can use on this platform, because my fear is that it harms so many patients, and I really feel for them while they give into these moments of weakness, and I understand where it's coming from, because if today somebody promises me that I'm going to cure you 100%, it's devoid of any side effects, uh, it's only there is nothing so pure in the world which can cure you, have no side effects. And I tell them the only thing that can be so beautiful is Amrit. And most of the gods also do not get Amrit in the Sagar Manthan of life. So that's the harsh reality of Shankar Bhagwan still having his Nilkant with all the poison sitting there. So beautiful theory of being able to cure what is incurable, and selling them a simple tip of eating a certain fruit at certain lifestyle at time points. I really wish and dream that cancer was so easy to treat.
Yeah, they are selling hope, and that's really very unfortunate. But that's the reality of life we have to deal with. So, in the light of everything, all the social media and everything, how should our patients choose the right doctor and the right hospital?
And hence, very honestly, I'm genuinely proud that you are doing what you do on a Sunday morning, in spite of running around the hospital Monday to Saturday, just trying to fathom the quantum of work that you do. I think we as physicians don't do enough to spread the science that we are doing. You don't have enough Prasad Dandekars available online because they're busy seeing patients, but you have enough real makers telling you what not to do. So I believe the onus is largely now on us as physicians to spread the word of what is right and in the most scientific manner. Two, three things that I often tell a lot of my patients is that when they ask me that, oh, whether should they go to a gastroenterologist or a B gastroenterologist, I always insist that please check the degree of the doctor who's treating you. Is he trained enough? Rather than Googling his reviews, which may be manipulated, you Google his degrees to find out whether they have the right affiliations and the right scientific training to treat you. We do that diligence in everything, right? When you book a hotel room, you find out what is the kind of hotel, what are the stars. Similarly, before you walk into a doctor's cabin, do the right kind of diligence. Whether he has enough scientific degrees to be able to address your question, is he the right doctor for you? You cannot be going for a medical oncology problem to a surgeon or for a surgical oncology problem to a physician. Also knowing is this what kind of doctor you need is very, very important and often decides the discourse of the cancer patient's journey. Going to hospitals which have all the right accreditations and historical ability to treat those patients is extremely important. One often believes, for example, for chemotherapy, you know what, doc, I got my surgery done in Breach Candy or a Reliance hospital with all the bells and the whistles, and now the doc said you just need 12 cycles of chemotherapy. Why don't you go to your nearest nursing home and get your gynecologist, take the protocol from Tata Memorial or HN Reliance and just get it delivered? Why you want to travel all the way? That's where the trouble starts, because now you're being delivered a certain kind of therapy which requires immense expertise in terms of anticipating, preventing side effects, and now your cancer experience is suddenly not great because you are the person who's giving you some treatment is unable to solve or anticipate your queries. So going to well accredited centers which are known for doing certain kind of therapies, and also checking the basic degree of your patients is so paramount importance, is of so much paramount importance when you choose your right doctor.
Yeah, and that has become very difficult now because there's so much information available about everything, and patients sometimes get confused. So I also tell them that you first, look at what has the doctor been doing and what has been their degrees and reputation overall. And I guess in our field also, word of mouth plays a big role. I mean, if a patient has met you, they are going to recommend your name to other patients. So I also encourage them to just, if you're confused, just look around and also take multiple opinions. Because sometimes it happens that you may have two very good doctors, but you may vibe with one and not vibe with others. So I said, your doctor is your partner, and you need to select your partner in this journey very wisely. Don't just go by somebody saying or some Instagram saying ki this is the right doctor. You need to have that trust and respect, relationship based on trust and respect.
Completely agree. I believe second opinion is the basic right of every patient, and often one looks at these patients differently if they've come to you for a second or a third opinion. But I believe the fact that somebody has come to me for a second or a third opinion, it means that he hasn't understood what he needs to understand very well, and he still has unsolved queries. So I believe the effort from the physician should be far greater into allaying their anxieties and answering their question rather than doubting their intent. Oh, why are they here? They've met four people. I'm the fifth one. All the more reason to spend 10 more minutes because they clearly are confused. They clearly have not been held their hand. If somebody hasn't held their hand enough to explain the journey as they would want to. So I believe, in fact, I encourage most of my colleagues to spend more time. It's not really about trying to own the patient's journey. It's more about empowering them and ensuring that they get the right advice, and then let them take therapy which is closest to their logistic space, and not trying to ensure that they stick to a certain organization or a certain place, because that is so unfair to a patient. So for example, if you have a patient who's staying in Nalasopara, which is about 80 kilometers from where I practice, and I insist that it's only me who can cure you, rather than spending those 15 minutes empowering of what to eat well, how to take the right treatment, and then refer him to a friend, a colleague whom I'm sure would do the work as diligently as I would, that dramatically improves their cancer experience in general.
What do you see as future of oncology in India?
While in general, cancer in India or cancer in the world, the ultimate, dream of any oncologist is to be able to create tailor-made solutions. I hope that for every patient, I have that one therapy or one pill which dramatically reduces the risk of the disease coming back. And that involves a lot of pharmacogenomics, pharmacodynamics, next generation sequencing of the tumor. While we would want to give the most highest evidence based care to every patient, we realize there is a yawning gap in cancer delivery systems. Not everybody can afford to walk into a Tata Memorial or a Sir H.N. Reliance hospital, and the entire world or the country cannot have 500 Tata Memorials or 500 H.N. Reliance hospitals. You need to have a beautiful symbiotic, synergistic cancer care models where you delegate certain complex cancer care therapies like complex surgeries, complex radiation treatments to these apex centers. And you also invest into creating cancer care community based models which are delivering the same high quality medical oncology experience, and then get them around these large centers of apex to create a hub and spoke where you can suddenly democratize cancer care. Previously, dare I say, the cancer care delivery was a fiefdom of large apex hospitals which require massive capital infrastructure, and a patient would often wait for days, weeks for their systemic therapy to start. Then came this entire generation where these medical oncologists would start walking out of these large hospitals and start delivering these cares in, dare I again say, small, dingy nursing homes where they could not control the cancer care delivery and the experience post the delivery. To now, world moving towards a lot of community cancer care centers, MOC being one of them, and there are so many such daycare community oncology centers doing very high quality oncology work. They have been there in global north for the last few decades, and they will probably proliferate in a country like India, because India has very, very plural needs. India needs Tata Memorial Hospitals. India needs Sir H.N. Reliances of the world, but it also needs small, bespoke community cancer clinics which can deliver care in the same qualitative way without having these patients needing to walk into these large care centers. And hence, suddenly you're creating a level playing access for most patients. I believe in the next 10 years, the large prerogative of us as oncophysicians and US radiation oncologists would be to certainly homogenize cancer care, where we're able to do 90% right for most patients, and then for those right patients, probably stretch ourselves more and give them that entire next 5 to 8% of cancer care delivery. Uh, Trying to do 100% high quality cancer care for every individual is a wet dream that most of us have, but there is such a massive divide between haves and haves not that I think the prerogative of the current generation of oncologists, while I would want and love to do a single specialty sub oncology practice, I would want to only treat breast, I would love to treat only breast and colon cancers for the rest of my life because I believe I treat them better. But if I stop seeing all other subspecialties of cancer, where would these patients go? So I think the next 5 to 10 years, the community oncologists should try and ensure they provide the same homogeneity of cancer care experience, which will take away these long-standing myths about how bad chemotherapy is. And the next generation of cancer patients would be your best messengers of ensuring that people take therapy. And then for those right patients who require a comprehensive, people who have stage 4 cancers, people who have complex cancers, ensure that you have enough minds working together to deliver the best in care. Cancers can never be treated alone. They can never be treated by a single medical oncologist or a single surgeon or a single radiation oncologist. They are best treated in groups. Uh, isn't that how we deal with most problems in our life? We'll deal with problems as a group. Similarly, always invest in having people who are there in groups, either physically or virtually, who have the network of people around them, which can ensure that you fight with this not so deadly disease better. I believe it's a myth that it's a deadly disease. The myth created by us to let the world listen to cancer and invest in research. But let's agree to a fact that a patient dying of an early stage cancer is more of an aberrancy rather than the norm. Uh, 1 in 100 die of a stage 1 breast cancer patient. 5 in 100 die of a stage 1 ovarian cancer patient. Less than 5 in 100 die of an early stage any solid organ cancer patient. So it's really a myth that cancer kills. And let's fight that myth.
Absolutely. And you have done something, and I want to highlight this because you have been very modest. You have single handedly changed the access to oncology care in Maharashtra and now in India by creating a very strong brand like MOC. And I'm so happy to see the rise of MOC centers that is happening, because I mean, I visited a few MOC centers, and what struck me is that everywhere I go is the same quality of care that the patients are getting. The other day I was talking to a patient, and she was talking to me about her breast cancer chemotherapy, and she said, doc, the best part of the chemotherapy was I had a lot of problems while taking it, but there was a nurse sitting next to me at MOC, just stroking my hand, and that really helped. And that's the kind of quality care that we need to provide. And what you've done is democratization of this access. So we have apex cancer centers, apex tertiary care centers, and not everybody can go there. And going to a single specialty unit is really, really helpful. And I'm sure you have many more centers to open. What's the count now?
So on last count, we have about 25 centers and we have about 48 medical oncologists working across 4 states of the country. I believe this is an alternative cancer movement. A decade back, I would say it's the ARP of oncology. Uh, Now I'm not sure if that's the right analogy. I believe we need to create centers which are very friendly to two large pillars of oncology. One is the cancer patient, and second is the cancer physician. Often, large apex centers of oncology maybe do injustice to both of these because of their prioritization. So the focus at MOC is, an MOC is created by a group of like-minded individuals, I being one of them, is can we ensure that the quality of a cancer patient and a cancer caregiver is taken care of? So our processes are defined upon how do I make a cancer patient's journey very succinct and fruitful. Can we have a single stop window for solving the problems? Can we have one person hand holding that patient's journey? Can we have an onco-nutritionist, an onco-geneticist, an onco-counselor sitting with every patient, understanding their needs and creating a precision-based oncology experience rather than having to give them more exotic medicines? And the answer is yes. At the same time, can I also uplift the quality of life of a medical oncologist? Rather than him having to run at 5 different hospitals trying to make mends, can I tell him that you just sit at one place in one MOC center, do what you think that you would want to do for your relative in terms of the prescription needs, and ensure that there are systems which can ensure that the quality that you would want delivered to a family member is delivered by that small center of excellence.
That's amazing. And best wishes to all your endeavors. And Dr. Maniar, thank you very much for joining us today. I know you run a very busy life, and I almost hounded you for the time. And thank you very much for giving in and not getting annoyed with my insistent requests for your time.
No, thank you so much, Dr. Prasad. And I believe you're doing human service. And while most of us get consumed by seeing our patients, very few take the prerogative to educate. And doing this on your own capacity as an experiment to improve a cancer patient's journey says a lot about how important is a cancer patient's life to you. And this is not done as a moment of transaction, as a moment of a marketing strategy, but to genuinely solve the queries. Let them get the right Instagram reels on their page rather than have some healer telling them otherwise. So thank you for taking this effort and having me here. It's indeed an absolute honor and a pleasure.
Thank you. And thank you very much to all our listeners for joining in. I hope you found today's episode informative. Feel free to ask your questions as a comment on this podcast, and Dr. Maniar and I will answer those questions
Sure.
with the correct information.
Most
Of course,
definitely.
please.
It's something
And
that we can
please,
promise.
absolutely. And please do like and subscribe to the podcast. But more importantly, please do share this information with people whom you love. And that is the way you can join us in fighting against this cancer. Thank you.